Good morning, everybody. Thank you guys so much for coming to our lecture on neurodevelopmental disabilities today. I am Jackie Sanders. I am a fifth-year resident in neurodevelopmental disabilities and have the honor of introducing Dr. Mia Asato, who is a professor of pediatrics at the University of Pittsburgh School of Medicine, and she is an attending physician at UPMC Children's Hospital of Pittsburgh. She completed training in occupational therapy right around here at Tufts University prior to completing medical school at Jefferson Medical College in Philadelphia. After finishing pediatrics and child neurology training at Children's in Pittsburgh, she completed postgraduate research training in the Department of Psychiatry at Western Psychiatric Institutes and Clinics. As junior faculty, her K-23 award focused on cognitive comorbidities in pediatric epilepsy. She continues research and training support related to activities within the Pittsburgh NeuroNext Clinical Trials Network. Her current role, primarily as clinician educator, she is program director of the Neurodevelopmental Disabilities Program and associate program director for child neurology in Pittsburgh. She's also the director of the LEND program of Pittsburgh, funded through the Health Resource and Services Administration, which provides interdisciplinary clinical and research training and leadership training, and fosters community-university partnerships around disability. Dr. Asato is active in leadership in professional organizations, including the Child Neurology Society, the American Epilepsy Society, and the American Academy of Neurology, among others. She's a medical advisor for the regional epilepsy advocacy organizations, and she's a section leader for AES and NINDS Epilepsy Benchmark. She's a member of the Hospital Ethics Committee, and she supports disability and transition initiatives through the university and hospital system. We are so honored to have her as our neurodevelopmental disability lecturer today. Her bio and all of the things we just talked about in the last couple of minutes don't even begin to explain the impact she's had on the neurodevelopmental disabilities field. One tiny impact she's had is she was the first person from whom I learned what neurodevelopmental disabilities was as residency, and she's influenced countless other trainees and physicians alike. So today, her talk will focus on neurodevelopmental disorders and the transition to adulthood. So please join me in welcoming Dr. Asato.
Thank you very much for that very kind and generous introduction, Jesse. And thank you to the residents last night who hosted me for dinner. It was really enjoyable and really makes me continue to be optimistic about the future of child neurology and NDD. So today I'll be talking to you about a topic that's really near and dear to my heart, which is medical transition. And these are my disclosures, which really don't have much bearing on the content of my talk. I will talk a little bit about the LEND program. And my goals today are to really talk about the barriers to successful transition, many of which you're familiar with. And we'll talk about this in the context of adolescent brain development and the critical refinements that are happening during this time in development. And we'll talk about unmet needs and opportunities to foster brain-informed transition readiness to hopefully improve long-term outcomes. And finally, we'll talk about legislative measures, because as we know that without some type of enforcement, it is very difficult for things to happen naturally to help our patients with transition. So let's talk a little bit about patient inspiration. This is my patient, Lucas, and this is to really highlight some of the points that we'll be covering this morning. Lucas was a very shy adolescent with ASD who came to my office after he had had what sounds like his second generalized seizure. And he was pacing around the room, and he handed me a checklist. It was a very crumpled piece of paper, and it had 3 things on it. It said blood pressure, heart, ears. And his parents explained to me that those are the things that he was expecting to experience during the visit. Now, I'll admit, as a neurology person, I'm not really good about checking the ears regularly, but I dutifully did so and talked to his parents about, what we would do next. So as we talked about his diagnostic workup, we discussed what we would be doing next. And over the course of our visit, I learned that Lucas was homeschooled and he went to the gym twice a week with a trainer so that he could work out. And then we started talking about what might happen as Lucas got older and what we would need to be thinking about. So over the subsequent several visits, Lucas would come to the office with his list. Although over time I noticed that the list would get a little bit longer as parents would add a few more things so he could tolerate the visit a little bit longer and we can talk about things in more detail. So, good morning. So early on in my medical practice, I dove into learning about transition and really got the initial impression that this was supposed to be a really well orchestrated process. And we were talking about this last night. It just sounds like this very nice dance where people go from one stage to the next, and it's a very straightforward, wonderful thing. However, over the past several years, I've been working on the hospital transition committee task force. We started working on transition policies and using checklists and the like, and we started hearing some feedback from parents. What were they saying from the other side? And I realized that even though our medical systems are so good at supporting transitional care, they were experiencing a lot of navigational barriers, and there was a distinct lack of optimism in terms of their young adults' future, whether they could independently manage their own medical conditions and handle work and education opportunities. So I thought for sure my role as a neurodevelopmental physician was to ensure the optimal outcomes, not just the medical outcomes, but more the overall outcomes development with patients with chronic disease. But really my health advocacy journey has really forced me to think outside my silo. So we all have a stake in transition, no matter what subspecialty we're really focused on in neurology. And what we know is that there are approximately 11 million children with special health care needs under the age of 19 in the United States. And about 20% of these individuals have neurologic involvement. And about 750,000 adolescents with special health care needs reach adult age yearly. Now, a study was done almost a decade ago by the National Survey of Children with Special Health Care Needs. And they interviewed families whose children were ages 12 to 17 and found that less than 30% had received appropriate guidance for transition. Now, that was a decade ago. And so I certainly hope by now we are much more aware of transition and we're all doing a better job in terms of addressing transition. But certainly this painted a picture that we needed to pay attention to the issue. So when you look at data describing the scope of children with NDD, you can look at various healthcare surveys and data collections. So in the large blue circle, you see children with special healthcare needs from this national survey, and that's the 11 million children. And about 20% of these children have neurologically based conditions. And then as you go to each smaller circle, you can start to look at different aspects of those children. So if you look at children who are receiving special education through the Individuals with Disabilities Education Act, you see about 6 million children. Children with disabilities, slightly smaller number. Children who have disabilities affecting daily activities, about 2 million. And then children who have disabilities receiving Social Security income is a lot smaller. Again, these data are more like estimates, but give you an idea of scales. In the state of Pennsylvania, the largest group of population that are receiving services are those with autism spectrum disorders. And about half of those patients receiving special services through state-funded waivers and the like, as well as through educational systems, more than half of those individuals are of transition age. And there's been about a 300% growth explosion in terms of what's needed in the state. So we see this as a real crisis situation in Pennsylvania. So why is transition a particular concern for neurodevelopmental disabilities? One of the main points I'd like to make today is that age is really not a reliable surrogate marker for maturation, and we all know that. However, we may not know enough about the maturation processes to confidently know when someone is really actually able to make that transition. And that state of readiness, depending on how we might define it, whether it's through brain maturation, functional status, is only just part of it. You know, there's a lot of issues around the caregivers, the family members, and the individuals themselves that can make this process very challenging. We all know as clinicians that preparing youth for adulthood has consequences if it's not done properly, and these are not unfamiliar consequences for you in terms of what can happen. There are risks for medical complications, problems with treatments and medical adherence, discontinuity of care, and higher care utilization and costs. Now, because And because of these factors, this is why a lot of caregivers and family members share ambivalence about this process and time period. And because so much of healthcare, 20-something-year-olds really don't need a lot of services. So the overall culture is really not oriented towards advocating for those in the minority population. So we in pediatric care are swimming an uphill battle. So this picture is really, I think, somewhat arbitrary and perhaps a little bit more enlightened over time. But you do have a dichotomy between the culture involved in pediatric care, which historically has been more psychosocial and focused, although we certainly see much more inclusive adult models that are based on the medical home. But certainly, care organization concepts can help move this type of transition along through ACOs, for example, but it's really just the beginning stages of thinking about this bridge that patients have to cross. So while today I'll be talking about the youth and the young adult's brain and their readiness for transition, I'm really not going to discount the many other roles that you're all aware of, such as the important role of families, education, social factors, access to insurance and transportation, provider accessibility, meaning access to providers both on the pediatric side but also on the adult medicine side, the important bond that's been established that can be hard to graduate from between the medical team, patients and families, cultural issues, and the presence of the medical home. Now, within the life course model, all these factors can really be promoting, but they can also be negative, particularly when there's a lack of some of these things. So a lack of insurance as a young adult or difficulty accessing transportation are really going to accentuate some of the health equity issues that start to evolve as people enter adult healthcare systems. So what is the doom and gloom on the other side of the proverbial canyon between pediatric and adult transition? So there are some important facts. So when you look at the Bureau of Labor Statistics, the proportion of individuals with disabilities who are employed still significantly lags behind those without disabilities. So about 20% versus 60%, which includes transition age youth. And then when you look at individuals who have individuals who have developmental disabilities, there's lower educational attainment, and they are 3 times more likely not to complete high school. And then across the board, you can imagine the economies of scale when you have young adults who are not able to work, and this costs society trillions of dollars due to inability to access social services and perhaps incarceration costs. So even within the most common neurodevelopmental disorders, such as epilepsy, unemployment rates can be 2 to 3 times greater than the general population. And even for the so-called benign epilepsies, there can be higher rates of unintended pregnancies and lower educational attainment. So the National Autism Indicators Report found that those who have autism compared to those with intellectual disability, emotion disturbance, and learning disabilities, the individuals with autism spectrum disorders have far lower rates of employment compared to their peers. So what I'm saying is that although employment is really not regarded as a medical outcome, not being employed, generating income and benefits can really be a jeopardy to one's physical health. So this figure, I think, helps us appreciate just the myriad of transitions that are going on. So while medical transition is something that is going on that we can certainly plan for and do it in a very thoughtful manner across many different specialties, this can really be traumatic for families just because of the other things that are going on. So at the time of diagnosis, one becomes very ensconced into various silos of care, which include educational systems, medical systems, social and health entitlements, and as one gets older, start to think about vocational destinations and housing. Now, I circled the family because at the time of transition, family members who have been so invested in their young adults' care, their roles can diminish, particularly because the transition age youth has legal status And it can be very difficult sometimes for parents to leverage their own contributions to that individual's care and advocate for them. And in addition, as parents age, their ability to physically help may diminish as well. So while our part may, again, be very well planned, well orchestrated, the other parts of this can be quite rocky. So what do we need to be doing as neurologists? So one of the points that I think is not very surprising is that transition really should not be an administrative act. When we look at all the evidence about what is the most effective thing to do, there's very little evidence base as to what are the effective interventions. So the Cochrane report that was done in 2016 reviewed dozens of studies and only came across 4 randomized controlled trials, which totaled about 238 patients, and really showed mixed results for various outcomes looking at transition. And the conclusion is that there's really no overwhelming evidence about the effectiveness of any specific interventions. So to this end, today's talk will focus on reconsidering the components of transition more from a brain-based model. We can really consider, as neurologic specialists, what's happening in the brain and use our knowledge about cognitive development and think about how we can use this for planning and policy for a more brain-informed process. And because we know that there's a shortage of physicians who are comfortable assuming the care of our graduating patients, we really need to consider our transition partners and direct our training efforts. So for some adult practitioners working with a patient, such as my patient Lucas, who hands them a list, may require some cultural exposure to improve care. So inside and outside the systems of healthcare, our laws and social supports are really defined primarily by age and convention, but increasingly have opportunities for our knowledge and science to inform policy. So an evolving example is how the developmental neuroscience field is increasingly informing policy with respect to criminal justice and the interventions for those who are incarcerated. So prior to the 20th century, the age of majority or adulthood was based on one's family and whether that individual was ready to assume adult roles in society, such as taking a leadership position, working, or getting married. And as more youth completed high school, this was transitioned to age 18 more officially when most youth had continued and completed high school. And they were also available to be drafted for military service as well as to vote. Still, there was some awareness that the brain wasn't quite mature, and people were aware of the fact that based on legal data and accident reports that exposing immature brains to alcohol could lead to more accidents. So that led to legislation across many states about increasing the drinking age to about 21 in those states. So Individuals with Disabilities Education Act has generally provided education for children till about the age of 21. There are some notable exceptions, such as Michigan, which will provide special education until the age of 25. Now, federal policy indicates that transition planning really should start at the age of 16 through the schools, although many view this as really being quite too late. And in the state of Pennsylvania, transition is really supposed to start at age 14. Now, in healthcare, the age of transition could easily be 18 for many of our patients, but our age of transition is now 26, partly in acknowledgement of the fact that a lot of patients have complex needs that are not easily transitioned over to other professionals in the adult sphere, and also because of health insurance coverage being available to help subsidize the costs of care until an older age. So like many other neurologists, as my kids barrel through adolescence, I'm really fascinated by the maturational processes that are playing themselves out loud in front of my eyes. So we're familiar with the structural refinements of the brain that include some changes in the gray matter compartment and the thinning of the cortex that goes well into the second decade of life, which is really thought to be related to synaptic pruning, expansion of the white matter compartment, and axonal diameter. And during this critical period, as summarized in the figure, there are numerous cellular, circuit, and systems level changes that really begin with the onset of puberty. So with puberty onset, there are increases in dopamine activity and availability that promote exploratory behavior that we're also fond of. And this is related to heightened reward activity, which in turn promotes experience-driven plasticity. And this plasticity is mediated by important balances between excitatory and inhibitory signaling. And through this, task performance can be perfected, local circuits can be stabilized, and then across the brain, there could be higher systems that are created and really lead to higher order cognition. So this protracted process in typical individuals is by no means completed by the age of 18 or 21 for that matter, under the best of circumstances. So the relevance for reviewing this type of process, today's topic, is really how this multi-layered developmental story contributes to executive functioning and their importance to successful transition. So, with refinements in the brain, structure, and function in mind, let's consider executive function. So higher order functions, such as changes in cognition, time management, metacognition, planning and prioritization, and changes in behavior, the ability to stay focused, emotional control, the things that I need to complete my day at work, are all very important and developing during adolescence. And they're very crucial to learning behavior and transition to adult life. Now, a robust developmental literature suggests that all of these skills are developing in early adulthood and really don't come online particularly fully through adolescence. And they're very sensitive to time, as well as biopsychosocial processes, pathology, and are vulnerable in many neurodevelopmental disorders such as ADHD, autism, and epilepsy. So executive functions are really quite useful to everybody, but when you think about how this might be applicable to transition age youth, there are specific skills that I think are really quite important to keep in mind and really should be made perhaps more explicit to all those involved. So developing realistic plans, sustaining your effort across the time, working on delayed gratification can be all important things, particularly in adolescents who really have a more reward-driven type of brain and can be really pressed to, they're unable to really see the long-term gains. So this can be difficult for them. And also regulating emotions in the face of adversity. So executive functions in clinical studies have really been important proxies for health-related quality of life and daily functioning. So in clinical practice, we can have neuropsychologists or psychologists who can assess these skills regularly. And certainly there are questionnaires that we can use as clinicians, such as the brief, that can be quite useful, but they do certainly take up time. So in our hospital, we've been really trying to roll out the track more globally. And for those of you who might be familiar with this tool, this is a validated measure looking at transition readiness. And it measures self-care and health utilization skills during this particular period of life. And some of the questions are really quite explicit and related to how much does somebody know about their particular medical condition? Do they know what their medications are doing? Do they know the side effects? But some of the other questions really get at executive function planning skills, such as, do you know how to manage your medications? Can you keep your appointments? Can you manage your daily activities? Those types of skills are really useful to ask teams about because it really helps exemplify where their skill level needs to improve. And for me as a clinician, this has really increased my awareness of how executive functioning plays an important role in getting teams ready to transition. And overall, it's under-recognized, under-assessed, and perhaps it could be under-treated and a target for what we might want to do to help youth as they go on their transition journey. So I'd like to spend a little bit of time talking about processing speed. And processing speed, as you know, is really the amount of time it takes for us to understand and react to information, how long it takes to do a mental task. And I certainly recognize the controversy about whether processing speed is really an executive function or it's really more of a foundational skill, and whether it's something that can be counted as executive function. But certainly, it can be very simple tasks, or you can layer it and add verbal and nonverbal components to it. And there is really quite a large developmental literature looking at the improvements in processing speed with age, and it really develops in a nonlinear way through development and is really quite sensitive to pathology and medications. Now, processing speed is a really important foundational skill because it promotes higher level skills, contributing to cognitive control, things that we talked about earlier, working memory, mental flexibility, planning, and inhibition. So in the developmental literature, these improvements in processing speed have really shown to be correlated to refinements in the structure of the white matter, suggesting that by using processing speed in the clinical setting, this could be an accessible part of an accessible toolbox where we can really track foundational executive function readiness in our patients leading to transition. So let's get back to Lucas. So his parents really wanted to discuss his future. They wanted to know what should come next after high school. Should he go to vocational training? Should he seek higher education? We knew about how his epilepsy was behaving, which fortunately was well controlled on monotherapy. We had some school psychology reports and an IEP, but it really was incomplete in terms of his parents thinking about what they should be doing next. And so I wanted to think about how we can think about his brain trajectory with respect to transition and thinking about executive functioning. So from longitudinal cohorts in individuals with childhood onset epilepsy, we know that there are impairments of reaction time as well as other cognitive and behavioral problems very early at the time of diagnosis and persist even after successful medical treatment has been initiated. From the Dutch study, even in children which they termed epilepsy only, school-age children demonstrated lags in cognition and had increased behavioral problems even before the medication was initiated. And from the Madison, Wisconsin longitudinal cohort, they had impaired reaction time in children with newly diagnosed epilepsy, even after they controlled for overall intellectual level. And this study showed an association between cortical neurophometry, processing speed, as well as processing speed relationships with the cerebellum and the brainstem, which really were not evident in the patients compared to the controls. And finally, decades later, after childhood onset epilepsy, there's a Finnish cohort which studied adults who had epilepsy 50 years ago, and they compared them to population controls and did amyloid PET imaging and apolipoprotein testing, genetic testing. And the adults in this cohort with childhood onset epilepsy, particularly those who were genetic carriers of ApoE, found that they had higher beta amyloid load depicted in blue in their brains at late middle age. They had no symptoms of dementia, but suggesting that this is an important biomarker for future cognitive impairment with age. So across these 5 longitudinal cohorts, we can see that there are early, persistent, and long-lasting effects on processing speed and perhaps some long-term effects as the brain ages. So what about the autism? So there are a growing number of longitudinal studies focusing on executive function in youth with ASD, and particularly focused on restrictive and repetitive behaviors and the link between that and executive functioning. So while processing speed was not necessarily studied in the longitudinal study by Kenny et al., adaptive behavior variance was explained in part by early development of executive function, in addition to early verbal and nonverbal ability. The authors pointed out the implications of disrupted processes supporting executive function at early ages could really set up the brain for delayed maturation of more higher level functions that really might be important towards transition, particularly in regions of the brain such as the prefrontal cortex. A longitudinal study by Hooper et al. Talked about boys with Fragile X over a 5-year period And they were able to demonstrate a positive growth pattern over a 5-year period in the boys over most executive function tasks. And there were significant interactions between clinical status and autism symptom severity. But there really needs to be more in this sphere of research to better pinpoint whether specific components of executive function are really important to things like cognitive flexibility, and to pinpoint whether they are prognostic in terms of their role in successful transition. It's unclear whether something as foundational as processing speed can really inform readiness of transition. And furthermore, the etiology of ASD as well as comorbid psychopathology certainly will have their own independent effects. I just wanted to show you a couple slides from the Hooper study looking at reaction time performance, and you can see that there are improvements of processing speed in both populations, in the Fragile X in the dotted line on the left, and then in the typical mental age matched peers. And then on the right, you can see that there's an effect of autism symptoms that were noted in the patients versus the controls, where there was a lack of improvement on working memory compared to the control population. It's a nice illustration how you can look at improvements in executive functioning, even in those with intellectual disabilities. And there are now many programs that you can see in the just general population offering executive skill training to college students, as well as individuals with disabilities like ADHD and autism. So there's a lot of public investment in these types of programs that I think we need to be paying attention to, and to really urge a more evidence-based approach to these types of interventions, because they really might be informative in terms of improving autism outcomes. So this can also be done on an individual subject level, and this is some single subject data from a pilot study I did with some of my students, where we prospectively looked at how individuals look using computerized cognitive testing before they were placed on anti-epilepsy medication. So we were able to do this in the context of clinical care, and we're able to do either 2 or 3 measurements in about 75% of the kids that we enrolled. So in this particular case, we have a 9-year-old young lady who was diagnosed with absence epilepsy. At the time of enrollment, and when we tested her, she was already endorsing difficulty with math and reading, and she was receiving help for this. On the second visit, her scores in composite memory dropped pretty significantly, and we used a measurement called Reliable Change Index, and she was at that point having some functional worsening. Her clinician referred them to neuropsychology, and by the 3rd time we were able to test her, she had already been diagnosed with ADHD, and an IEP was put into place. So this was a pilot study, but we found that even brief testing for 20 or 30 minutes could really be informative to patients and families and guide clinicians. We were able to formulate an algorithm that would help guide referrals to neuropsychology. So whether scores either stayed stable or declined, we were able to make referrals based on further feedback from parents. We use some screening instruments that are really quite quick. So within a 30 or 40-minute process, we were able to, I think, provide meaningful feedback to patients and families that we could certainly track longitudinally over time at fairly low cost. And we were able to also involve primary care with referral processes, involve the school, and utilize local resources. So it's really all fine and good to suggest that we should screen all of our patients. Certainly, there is not enough time and resources to do this type of thing, but there are lots of large-scale models that are doing this, and I think there's some good examples to learn from. So one is the Concussion World, who routinely uses data to decide if someone returns to play. The Children's Oncology Group does serial measurement and really evaluates the effects of treatment on their protocols, and I think this is something that could really inform perhaps epilepsy care and in adult dementia clinics as well. So while I'm not advocating that we get rid of gold standard thorough neuropsychological testing, in order to develop a toolbox that would really help us know where patients are in terms of this brain development transition journey, picking some very simple targets that we know are sensitive to changes or variants in development, but also other treatments we may be using, may be a good place to start. So I put down ecological validity there just because we know that trying to link something as simple as processing speed to larger outcomes such as psychosocial outcomes, employment, executive function is a pretty difficult feat, but certainly starting at something foundational is a good place to begin. So what could a model of transition look like that's more data informed? So in our LEND program, we have students from multiple disciplines from the allied health fields working together with NDD physicians as well as pediatricians, and we work with referrals from our Autism Treatment Network and the Fragile X program and address transition issues. And by focusing on youth-centered outcomes, things that are really prompted by their milestones or graduation and post-secondary plans, education plans, we can really integrate the large amount of data that is coming from these different systems of care. So we're able to talk to the schools, work with different community agencies, and also facilitate communication between the different specialties. And what I've learned is that it is incredibly time-intensive work. I think this type of model is very not necessarily realistic for what we need to be doing in daily multidisciplinary care, but we can certainly think of training models where we can do this and also think about other sources of funding to help provide those important people to make those translations. I think what the patients and the families learned most about this process was the understanding of the data that was really more relevant to overall life prognosis and understanding how neuropsychological data really led to skill building, and that was extremely useful to them. So by using health navigators, parent advocates in clinics, I think this could certainly be a way for families to start getting engaged in the process and certainly getting involved at an earlier stage. Through our adolescent medicine program, Children's, they are starting a youth leadership program, and that's subsidized through the Health Corps AmeriCorps program, and that provides leadership through peers, which I think is a very useful model when you're working with teenagers. So in a perfect world, I think it would be great to say everybody needs supports as long as they need them, but we know that is really not realistic. So if we were to make the case for extending supports beyond the age of 21, the goal would really be to identify those who could get to employment and perhaps be more independent in their daily life. For those who have the ability to become competitively employed, they could take advantage of different types of vocational programs, which exist in many states, and be supported by vocational rehab, which currently those resources are quite limited. And for youth who have disorders or their disruptions by their disease flares, these developmental processes that we talked about earlier are certainly in jeopardy. And so their ability to develop those critical skills that we talked about are certainly more difficult for them compared to other patients. Many children that we see with neurodevelopmental disorders do not get neuropsychological testing, and there is a service gap. And so there are programs out there, such as this one described by Wills et al., where they embedded neuropsychology into the sickle cell program. They were able to do brief assessment that was really quite relevant to medical treatment planning, as well as transition planning and school IEPs that previously was really unavailable to that particular population of patients. And this was viewed very positively by patients and families, but certainly there needs to be a lot of institutional support for these types of programs. So I wanted just to talk about some very important policies that I think are very important to us as physicians, because these promote social equity in order for patients to get to work. So the first one is the Workforce Innovation Opportunity Act. This funds the Office of Vocational Rehabilitation that provides individuals with disabilities with opportunities to develop skills for competitive full-time employment. And it ensures that all students with disabilities ages 14 to 24, as well as high-risk youth, receive pre-employment transition services, job exploration, receive training in self-advocacy skills, and this allows them to have opportunities that they otherwise might not be able to be successful in. And while OVR services can help double the employment rates, the number of jobs is still limited. So this legislation is going to be focusing, hopefully in the future, about giving tax incentives so that employers would actually offer jobs so the youth can assume roles in the community. In Pennsylvania, there are 2 House bills that help promote student employment. The first one, HB 400, ensured that students with disabilities could access part-time work and summer jobs and getting paid competitively. And House Bill 1641 was passed in 2016 to allow state entities to increase the number of jobs for youth with disabilities. Also in the works, promoted by your state representative Moulton, is the Heads Up Act, which is the Healthcare Extension and Accessibility for Developmentally Disabled and Underserved Population Act. And this proposal would link access for those with disabilities to healthcare centers and the public health infrastructure. And that's for the patients. For us as providers, and primarily focused on more primary care providers, this would include loan repayment and training programs, and importantly, incentives for higher reimbursement rates for services, and perhaps prioritization for research. So while I don't see this particular act specifically benefiting those of us in specialty care, it really could help promote building the other side of adult providers that I think is still a major concern for transition. So our society really needs to provide more systems-based care, starting with addressing poverty. I would say that poverty and health are really unfortunate close companions, and the National Council of Disability reports that many parents that we work with also are struggling with disabilities. The National Health Interview Survey showed that children who are in poverty are more likely than others to have disabilities, and this, as you know, puts great stress on families, their ability to maintain income, and has higher impacts on underrepresented minorities and low SES populations. Many patients also have mental health comorbidities, which compound their difficulties and make it harder to access some of the systems of care. Continuation for insurance and Medicaid through the age of 21 is really important, and not allowing pre-existing conditions to be imposed is something we should all fight for. Integrating medical records so that all systems of care can really access these things. Using technology and telecommunications need to be a pretty germane part of routine care, particularly for behavioral and developmental disorders. And finally, training adult providers is something that we should be considering, particularly for neurology residency, and providing real-time experiences and models of care that people can take into community after training. So I'd like to thank you all for your attention. Lucas's parents on their most recent visit told me that they were planning to relocate to another state where there are more community programs specifically geared towards autism and vocation. And on this visit, he did not give me a list. He shook my hand at the end of the visit, and it was really quite touching to me because he had come to a point of understanding in our routine of visits that he knew what to expect and that he felt comfortable about what was going to happen. So this concept of self-determination is very important and is not necessarily explicit to most patients and families. It's something that we build into our transitional care, but we need to make it more explicit so that the youth will pick up on it. And the mentoring that we do has great impact on patients and families. So I'd like to summarize, and I hope what will follow will be a discussion about some solutions that you might be working on in your healthcare system. But the state of transition in the United States really highlights some important health and social equity issues. We can certainly build a very marvelous bridge to adult care, but we really have to address some of the disparities and some of the economic issues that they're facing. We know that patients with neurodevelopmental disorders are at risk for more compromised outcomes compared to some of the other chronic diseases that we may treat in pediatrics. And we have talked a little bit about the structural and functional refinements that are occurring in the brain that really help support transition. We can certainly do much more monitoring and mapping trajectories of executive function on an individual level, but also across patient groups. And we can perhaps over time start to advocate for policy that would allow funding to continue for those with disabilities so that they can reach employment status. Finally, we also know that starting to support policy should be occurring earlier in development, and we need to increase access and expertise within adult care. So in conclusion, I would like to thank the patients and families that I've worked with over time. I think I've learned a lot about the journey of what it means to have a neurodevelopmental disorder. I thank my division and in neurology, as well as the child development unit, as well as the LEND program. Some of the work that was done earlier with the epilepsy patients was funded through HRSA and some of the students I've worked with and some community partners. But I welcome comments and questions about what's happening in Pennsylvania, but also would like to hear what's happening in your community as well. So thank you very much for your attention.
What your experience is, yeah, zoom out to the other side, like what's your strategies for sending the appropriate information and for a successful solution?
We've mostly operationalized it for epilepsy, so we have a letter template that summarizes the important details around the epilepsy-related care. We are starting to work with the adult program around a HRSA grant that will use telemedicine, because the concept of having adult and pediatric providers in the same space sounds very appealing, but logistically is so complicated. So we are trying to work towards using telemedicine so that people can walk up to the telemedicine suite from their pediatric visit and then meet their adult provider. And just that initial contact might help facilitate the continuation of care. We see a lot of people who go and then come back. So that's still a problem we need to work on. With regards to the other care, other diagnoses, we have neuromuscular specialists who are designated as receivers of individuals with some of the muscular dystrophies, for example, but I would say there's no uniform process. And giving people more opportunities to work with outpatient populations during their child neurology experiences for the residents is something that I think we should do more of. Yes.
Certainly, to take our interest in supporting the education and the attainment and formation of children that we take care of is important, but there will be some who are out of the range of that possibility and are out of the range of the. It seems like we need to build our transition models to take all into it. We spent a lot of your talk today talking about how do we, bring forth our philosophy of providing support into later years and get over that transition. But what if for the cases that's not possible? Is it realistic that healthcare systems can agree on whether everything has insurance, much less equity and how do we realistically today begin to put together this transition in a realistic way? I think that educating all providers, to be able to take the on educating ourselves and our patients what life would be like on the other side of it. Why is a really important part of it. I don't know how we can do that.
Yeah, I think starting early, right.
Yeah, we're going to need, we need help.
We need help and funding, right? I think there's a lot of, funded programs that can help facilitate those conversations and building those relationships. I think that certainly doesn't happen by itself. I do feel that there's going to have to be some rationing involved, because I just don't think it's realistic to provide services indefinitely to everybody. But to me, the greatest amount of hope that we can have is that people can achieve employment. And I think we need to identify those people. And we know that in studies with individuals with autism, their ability to gain employment may be behind anywhere from 6 to 8 years behind their peers when they're ready to enter the workforce. We have to build their skills. And I think that's how we can influence policy, is knowing our patient population, knowing our particular patients, and advocating for them on an individual level. And if the age of support through the educational systems is the way they access vocational programs, then following Michigan's example, for example, Michigan's example might be a way where we can advocate for them. But it'd be hard to do it on a population. Well, I think that's a time when people can gain those skills. I think a lot of our patients just aren't ready at age 21 to enter the workforce. And we know that from limited brain data, and we need to collect more of it so that we can show that there is a link between development of these skills and when they might be ready to enter the workforce. And there's a fair amount of vocational data that I think perhaps we're not very fluent in, that we can start to engage to inform policymakers. But I agree with you. It's the whole thing of thinking about this world as whose pot of money is it, and who's going to be responsible, and who's going to pay for it. Right. Right.
Or have our patients have to move someplace else to get what they need. And we have a realistic assessment of the situation, whether we have control over as physicians.
Right.
And try to build programs of communication and us.
Very simple, as I told them all the time. I do feel that it should be in my normal context.
Right.
Other medical, if we sort of create like pathways for areas or strategies, epilepsy, those are concrete steps that we can use.
Right. Absolutely. Oh, indeed. And I certainly didn't want people to think that they have to become really involved in some of these psychosocial issues, but I think to help you appreciate kind of the dimensions of it, and that I personally believe that focusing on employment skills is going to be really important, more on the pediatric side, to help parents see the vision, because their child may get there. It just may be a longer protracted period. Sarah.
So one of the things you asked about is what is going on in our state. I can't say across the state, but what we are doing right now is trying to get people across the state together. So we have a plan for started really with children's and local bridges programs that work with Women's Hospital. And so it hadn't been really dealing very much with neurodevelopmental.
Right.
It's been dealing with other complex healthcare needs. And so we kind of stole Susan here somewhere, so work for some bridges, and said, let's work on neurodevelopmental disabilities, because as hard as it is to find an epilepsy person or an adult headache person, it's even harder. There is no equivalent of neurodevelopmental disabilities for behavioral pediatrics
Right.
in adult world.
Right. We were talking about that.
One of the things our patients are having is finding adult providers. So we have a plan for this year. We've got people from across the state, K-State, from all across the state, not just from every hospital. But also people from state agencies, from the Division of Developmental Services, from the Department of Health, to get together in identified 4 themes. So we're working on task forces. And then we have a plan to have a summit in fall of 2020, where the task forces that are going to work on workforce development, there are 4 themes of workforce development, and clinical pathways, figuring out what is the best way to give somebody infrastructure and resources. So that idea of the physicians should do their physician thing, but there probably are a lot of resources that we could put up on the website that could be shared across all of the state of Massachusetts, right? I mean, all the DDS services. It shouldn't be every everybody recreating the wheel and figuring out what we do. And then finally, kind of how do you find it?
Right.
So we want to work with the insurers, we want to work with the admin people from the ACOs to say, how do you bill these patients so you actually get reimbursed for this extra time that it takes? Because I think that's one of the things that
Right.
nothing's going to change. Nothing's going to change until you actually get paid for it.
Right. And I'm not sure. Right. And I think physicians are, a very expensive part of that. So I feel like it has to be other people. I think it needs to be, educating community advocates, allowing them to be part of that visit somehow. I think there's a lot of issues around HIPAA that we have to work around, but I do feel like through our Autism Treatment Network, we're starting to talk about parent leadership boards and things where we can start to have navigators, other people, because I feel like we all have to work at our highest level. I can't be a social worker, I can't be a neuropsychologist, but I can see the whole landscape, and I think we need to think about who else we can engage on the healthcare team and in the community to help us do some of this work. Good points. There's somebody over there. Yes.
I would love to hear in the future about how we segment of our population percentage, because the transitioning from that population was even more fluid, with fewer adult providers. And there's a whole range of other transition related reports that this population needs, already long-term care plan, all the government programs that they have to connect with because they can't employ themselves. I think that presents more ongoing discussion.
Right. And I think that was what you were kind of getting at, Dr. Hamari, about the fact that most disabled patients, we have a big push in Pennsylvania to deinstitutionalize. And so trying to find care and residential options for our patients with very complex care needs whose families really can't assume that responsibility is a big issue. And so we're having ongoing discussions about what is the best solution for just routine care providers, and then trying to talk about transition in a way that's meaningful to that population. So I agree, very challenging. Well, thank you all. Thanks for your attention.